All right, so one of the themes of, or I guess the theme of this year's summit is kind of bridging gaps and doing translational work. So my first two questions kind of address that theme. And the first one is, and this I think is hopefully applicable to everyone, but maybe we could start with Dr. Turner, is basically how can we translate these really exciting tools, and how are you perhaps already translating these exciting tools into a more practical setting to really help people?
Right. So what we're doing right now, we have the data component of Crisis Text Line, and obviously the help that we're bringing to populations across the country and actually globally, because we've expanded into Canada and the UK already. But the way that what we can do, what we're looking to do next, so it's a startup still in its 5th year. What we're looking to do next is to develop a Crisis Trends Institute where the data is much more useful to policymakers, to those who want to utilize the information that we're collecting. I mean, we have a huge data corpus that's not necessarily as user-friendly yet for researchers, for policy purposes. So I'm hopeful that our next steps will really be translational in that way, so that people can utilize, so that researchers, so that policymakers can utilize the data that we have stored anonymously down to whatever local level would make it most helpful and useful.
Anyone else like to add anything?
You can have mine.
I have a question. Your program is fantastic. As a physician, this is a little bit off topic, but we're always worried about liability, and I was wondering how you've managed that with this, because you've embraced risk, real risk, in a way that I think frightens a lot of psychiatrists, and you've done this on this large scale with people who you don't know their names, et cetera. How have you managed that aspect?
So we have an eye on risk always, an eye on confidentiality, ensuring that our data is scrubbed, that we are at the forefront of GDPR standards. So the key is ensuring that our general counsel is always involved, right? So it is risky. So there's risk in terms of those who we are not able to save, right? We do not purport to be therapists, so our volunteers are any individual with obviously background screening and a significant application process can be a volunteer, but so we do put ourselves out as a crisis intervention service and not as someone who's providing therapy. But there's always the risk, right? So where someone has reached out to us, as I understand it, the liability, as a volunteer organization under Good Samaritan laws, we are doing our very best to help those who are in need. Obviously, we are not always successful, but we have a protocol in place to ensure that we're doing the best crisis intervention services in the moment.
Okay, so my next question, again, anyone can answer, but I'm imagining this will be directed more towards Dr. Checki and Corcoran, is one of the main benefits, I think, of a machine learning approach is that we get this high accuracy, but there's always that fear of overfitting. So I'm just wondering, how do you look towards this issue? How do you address it? And especially moving beyond maybe the English language to help other people. And I know you've done a little bit of work on that, so I was hoping you could speak to it.
Well, I already made my disclaimer at the beginning. So we try to do what's called cross-validation, which also has its problems, but we are limited by the sample size, and what we say is, well, we have an insight, and the only way to prove this is to have larger data sets. Something that we're trying to do with Travis is even go across protocols, trying to see that there are universal markers. And yes, we are working across languages too, and across cultures. But until we have significantly larger data sets, it's going to be partial and preliminary. So Cherry, you want to say more about that?
So I would just add, in the data that I presented, the first one was clearly overfitted, right? It was 34 people, and we had 5 in one group. But we're feeling a little more confident as we bring in separate cohorts, and then we're finding the same variables. And I have an RDoc grant, actually, to collect language with Guillermo in English from more than 450 people in Canada and Australia. So we want to see if it has legs and is correlated with other measures.
Great. And I've got one more, and I think this is directed more towards Dr. McCoy, but again, for anyone, and remind me to give back the microphone that I stole from you. And that is, you spoke a bit about, I think, this tension that exists between, the predictive accuracy and some of the nonlinearity that comes from machine learning is its real strength, but then this tension of, clinicians in particular wanting interpretability. And I'm just wondering, how have you worked through balancing that, and kind of what are your thoughts on that? Really, I think, important question.
Well, I mean, yes, there's an inherent tension there, and I think the answer is you have to know what problem you're solving. So when we sat down and tried to predict suicide in our post-discharge patients, the goal was to have a good model, not necessarily to know how the model worked, and we knew that if we got a model that was good enough, we could deploy it and we would know what to do with it. And so there was a very clear specification for the problem there of kind of make this prediction, do this intervention if the prediction is good enough, versus try and find something which is essentially true globally in the world and root that truth in biology so we can target it. Those are, in my mind, actually pretty easy to differentiate project goals that sometimes we play a little fast and loose with.
Let me add something to that. So interpretability is a whole field in itself now within machine learning. And so in the lab we have an entire group dedicated to this. And for instance, recently they came out with an approach where if you have a good deep learning model, you can map that into, for instance, a decision tree by selecting, by filtering your samples. So this is a problem that's being addressed, and I think very soon we'll have approaches to extract the interpretation that you care about from a complex, high-dimensional model.
It's very exciting. Do we have time for any questions from the audience? Yeah, please.
Steve Locke, Beth Israel, Deaconess Medical Center. I'm very interested in how the transdiagnostic model is going to fit into current efforts which are moving towards using standardized diagnostic interviews as part of behavioral assessments, oftentimes integrated into treatment programs in order to stratify the population. Currently, people use some structured interview, which is basically based on either the SCID or based on one version or another of DSM categories. But those, I haven't been able to identify any structured interviews that are based on the transdiagnostic model. Do you know of any?
I certainly do not. I will say physicians at Mass General, by and large, would rather not do structured evaluation, and take heart when I say, well, you can just do your evaluation and we'll sort it out in software later. That may not be in keeping with the times, but it does certainly resonate as appealing. So we're sorting it out on the back end right now.
I can actually answer real quick that there are, I think, in development some of these things. So there's, if you look at the alternative model for personality disorders, there's the AMPed model, there's the SCID AMPed, and those domains correspond broadly to like the high top domains as well. And then there's the PID5, which is a self-report measure that's quite extensive that can give you those things as well. So I wouldn't be surprised to see, very soon, something like the SCID-AMP that's extended for not just personality disorder, but, more broad, common psychopathology as well.
I just wanted to add that, and you probably know this, but you analyze the records. I've certainly put entries into records, and so we have time constraints, and diagnoses are often made for billing purposes and all sorts of other things. But I mean, that's where we practice, is that that's the structure of reimbursement, is to have a DSM diagnosis. So whether we get that, figure out the syndromes based on a structured interview, or we know the syndromes and we just ask, I mean, that's where we are now, right?
I have a question for Dr. Turner. My name is Jeff Winchell from Harvard. I was very interested when I saw that statistic in one of your slides go by that said trends in, you were mentioning trends for public policy for crisis. And there was some number, it was like 18%, went to 23%, and just from 2016 to 2018. I think it was in people using the line or being in crisis or something.
18%. What is, oops, sorry.
So my question
Yeah.
is if you've investigated this statistic to understand why there was such a large jump, I don't know if it was your population has changed or the world has changed. I mean, yeah, we have a new administration, but I can't blame all that on that.
Okay. Oh, okay. Well, I think we're having continued growth. So as an organization, I didn't have that particular slide in there, but our volume is continuing to grow. So and we're able actually to capture spikes in national crises. So we'll have an increase in volume, time limited, around the 2016 election. We anticipate a spike in volume for the upcoming midterm election. We had a spike in volume for when the release of 13 Reasons Why. So our data is real time in that way. So as we see increases, I think our data parallels national trends in terms of increasing risk or increase in suicides. But I think what's key to crisis text lines data is that we're able to parse out specifically for a given area, for a given population, for a given age group, the incident or the prevalence that suicide is discussed or self-harm. So I think just in general, the real-time nature of our data allows us to capture changes and trends in that way.
Perhaps time for one or two quick ones? Yeah.
Yeah, Dr. Turner, I just wanted to say that the program and everything that your organization is doing is just incredible work. So thank you. I just wanted to hear your thoughts about expanding this kind of work globally, especially where mental health care is not very accessible.
Right, that's a great question that we are actually working on. We have the next 5 years are focused on global expansion. So as I said, Canada and the UK have already started. We are powering, our data and our technology is powering the services in those two continents. And we're now looking to partner in New Zealand. So we're looking first for English-speaking countries, and then looking at how we can partner with other countries who are non-English speaking but clearly in need of services. So we're starting with the areas where it's obvious by language and existing infrastructure where you can mobilize, as we did in the UK, a volunteer network where they have the equivalent of the ability to do active rescues to help people. And then we will be pushing forward into non-English speaking, primarily Spanish and French to start with, countries. So we have a global expansion plan recognizing that mental health services, especially in third world countries, can be limited in access or non-existent.
I have actually 3 thoughts, and I'll put them out there. There's probably not enough time to discuss them all at this point. But and for Dr. Turner first, it's probably a very hot button I'm going to press here, but your methods and your way of doing things, you can imagine, could be applied to websites like Gab or other things that have been used most recently by people who are actually going to go out and shoot other people. These are not typically help-seeking people like your texters, but you can imagine that you could use similar methods to predict who's about to do a violent act. And I wondered if anyone's talked to you about that, or, I mean, I know there'd be a lot of privacy issues that would have to be addressed, but it seems to me that it would be a parallel application of sorts.
So if I'm understanding your question correctly, is the concern that someone would utilize our text line for?
No, sorry. I mean, and it's actually a food for thought, but the actual text analysis methods, such as that you're applying, but also the same things that Guillermo and Cher have applied to predict who will have a psychotic break. You can imagine those things being applied anonymously to all kinds of open forum websites that, I mean, Pittsburgh's on my mind right now because I'm from there, but things like that might be able to predict someone who's in a different kind of crisis, and that is the crisis of going out and planning to hurt someone. I just kind of wanted to put that out there. I think that's, I don't know, it's something to think about. For Dr. McCoy, I was wondering how the richness of your data will hopefully change when people have the opportunity to put their own words onto the health record. As a person who's, as you know, even those little notes by the clinicians at the end that are their own words can be very stereotyped. Your experience as a patient is that you go in with a very idiosyncratic description of how everything's affecting your life, and your physician just says 3 things, and you're like, the last 20 people he's seen, but those 3 things. So the object of the physician is to distill this into a diagnosis, which means their information onto their health record is very stereotyped, that they use the same phrases all the time, whereas each person is going to be very idiosyncratic about the way they describe that. And I'm wondering how those things are going to, meld with each other to actually give you better accuracy.
Yeah, I think that's a great question, and one that's certainly coming, right? I mean, we know we have the big Open Notes initiative, which is pushing physician notes to the patient, and in sort of collaboration with a couple of technical blue chips, we're working on ingesting patient-generated data into the health record. Right now, that ingestion is not primarily focused on text. It's mostly remote monitoring of physiological variables. But I think it's inevitable that text will come, and that will be an exciting opportunity to do new work. I think it's very unlikely that a model of sort of physician speech is going to have much relevance to patient description, but we're learning how to do it now, and we can start back over then, and that'll be exciting.
Yeah, I think so. Just lastly, for psychiatry, so with Dr. Corcoran and Ketchy's models, the thing is that you're using language to be predictive of a diagnosis, and it kind of comes to this deeper question of why we as humans feel the need to categorize. I mean, in psychiatry, we categorize. That's what we do. And what is the purpose of categorization? Is it to predict future behavior? Like a diagnosis of psychosis, what does that mean to us? It means we can predict maybe what that person's going to do next, or is there a different purpose of categorization? But ultimately, having a model that then serves to predict a category that a physician will use, we have to actually ask what was the original purpose, or what is the original motivation behind that category that we're trying to predict. And I think that's going to be the stickiest problem when it comes to this kind of technology in psychiatry. And I just kind of wanted your thoughts on that.
I think, Holly, that for what Guillermo and I are doing, it's really, if we can identify these linguistic features, then we can bring it back to circuits, then we could try to develop interventions.
And from the point of view of machine learning, we're using those as features to construct our models, but then we don't end up with categorical outputs. We end up with continual multidimensional outputs that we can use in tracking, as I was saying, tracking the patients even on a daily basis, right? So, but this is the starting point.